Hello everyone, this is Dr. Vince Cabag and I'm showing you a surgical video of phacoemulsification. So let's start. We begin with a stab incision here as you can see. This is using a 15-degree knife. You can use your cotton pledget to stabilize the eye. Afterwards, we're going to stain the anterior capsule with trypan blue. This will aid in our next step later on, which is capsulorhexis. Alright, so you can wash this trypan blue. You could, personally I will use lidocaine solution. You could even combine it with epinephrine to help in the dilation of the pupils. So then, after removing some of those trypan blue, we proceed with injecting our viscoelastic. This will form the chamber and would aid in providing stability to the eye. Okay. A good tip is to be generous in placing viscoelastic, because as you go along with the procedure, some amounts would actually escape, and this would actually cause some shallowing in your chamber. Anyway, so we proceed with doing our main incision using a 2.5mm knife. So that one there is a Wong incision, and this is now a biplanar incision. The assistant here usually irrigates the eye as the procedure goes along. Alright, so with that, one of the most crucial steps is your capsulorhexis. So there are various instruments you can use, as you see here. I'll be using a Utrata forceps for this case. So you can see in the diagram below, you could actually try to make a small strip, a small tear. So the Utrata has a pointed tip. So from there you could start peeling off this very thin anterior capsule. Doesn't matter if you do it clockwise or counterclockwise. Whatever works for you, you should do it as routine as possible to make it more predictable. So anyway, that's more or less the rhexis. So you want it at least at 5mm to accommodate the intraocular lens. 5 to 6mm should be okay. Alright, so after doing the capsulorhexis, we now move on to the next step, which is more or less before doing phacoemulsification. You want to, you could do hydrodissection to rotate that lens. In this case, I will be doing a different maneuver. So anyway, we remove that portion there. Right, just remove a bit of cortical material at the anterior surface, and this is like to do. That's what I call a mechanical dissection. You could do another video on this. Another concept of mine called this PH.PH. Basically, you like mechanically rotate the lens with your second instrument or your chopper and your phaco tip. So that was a good initial chop. So let's try to bring this 1/2 anteriorly. So we're now in the phacoemulsification part. So I like to use my chopper to prolapse this this chunk, and once it's a bit prolapsed, you can now buzz in your phaco to remove that piece. So just make sure that you're in the center or in the safety position, and use your chopper to put it to bring forth any material to the phaco tip. Alright, so that looks good. So basically the next steps are really just to chop, to do the phaco, to rotate the lens, and repeat. So your goal here is to remove this nuclear fragments as efficiently as possible without damaging any structures. And yeah, so we have one more half here. So I tried to rotate this and flip it. See there, we managed to prolapse this half. Now we can now buzz in with our phaco and proceed with the nucleus removal. Alright. So this machine is well, for the resin, this is a peristaltic machine, so you need full occlusion to actually achieve a vacuum. So it's important to use your chopper to really bring forth those fragments to the phaco tip. Alright, so that's gonna make the last nuclear piece. Looks good. And then our next step will be just to irrigate and aspirate the remaining cortical material. Cortical material is less dense and it's a bit softer, so you don't really need the phaco power or the ultrasound to really remove it. You just need vacuum. So this is a different tip. So using a co-eggshell. Some prefer to do bimanual, in which there's two instruments, one for the irrigation, one for the aspiration. Alright, so let's try to center the video. So this is a bit off center. Alright, that looks good. Okay, so we're now removing some of the cortical material, if you can see there. This yeah, so we want to make it as clean as possible before implanting our intraocular lens. So you could do different ways. Some would prefer to do the subincisional cortical material first, because that's usually more difficult. In this case, I actually did other areas first. So yeah, later on we'll have to deal with the subincisional fragments later. So you have to be systematic. One way is to just grab a portion, a generous portion, and then slowly move it to the bring it to the center before you push the pedal, a step in the pedal to really apply some vacuum. All right. So make sure you do all clock hours to really remove all those cortical material. So what's gonna be left is just a capsule. All right. So just to review, the lens has this inner nuclear material. It's the most dense one, and then you have an epinucleus, and then the cortex, and then the piece that we will leave intact is the capsule. So that will be the capsular bag. That is what supports our intraocular lens. So you can see actually I'm struggling in the last part, which is the subincisional. But yeah, you just have to take your time and make sure that you don't risk damaging the posterior capsule. So what's separating this part here from the vitreous is just this thin capsule. So beyond that is actually the vitreous humor already. Okay, so this is the last piece, cortical piece. So it's a bit stubborn, but well, yeah, with patience we could get that. Or alternatively, if it's really just peripheral, well, the less is more belief can also be applied. But anyway, I guess in this case, are we gonna get it? I think we can. So yeah, I got a small part of it and just trying to apply traction, bring it to the center, and yep, we got the last piece. So that is essentially cortical material free. Now we're ready to implant our intraocular lens. But first, we need to inject some more viscoelastic to inflate that capsular bag. So as that gets inflated, there will be enough room to inject our intraocular lens. Alright, so this is what it looks like. You can actually appreciate the positive red-orange reflex at this point, since the cataract is already removed. Anyway, so after putting some viscoelastic or whatever gel you're using, we now proceed to implanting our intraocular lens. So I use a second instrument to just guide the intraocular lens and make sure that it really goes inside this capsular bag. So these lenses are foldable, single piece, and it's how it looks like when you implant the lens. So just slowly, it'll slowly just go inside, and yeah, you could use your other instrument to just guide it and make sure it doesn't go too anterior or it goes yeah, at the sulcus or at the anterior chamber. So yeah, that looks good. You could actually even rotate it with the second instrument, or you could just use your irrigation aspiration probe. Anyway, so this is the next step. After you've implanted the lens, you also want to remove those excess gel that's inside the eye. Why? Because if you leave some of the gel, then that could actually cause some intraocular pressure spikes. Okay, so those gels, the viscoelastic, can actually clog your angles or your trabecular meshwork. So you can see I'm removing some of the gel. It has served its purpose. So now we're going to try removing some at the back of the lens. And yeah, after removing some gel there, you could also remove gel at the more anterior portion or in the anterior chamber. There are many kinds of gel. So in this case, I use Viscoat. So this is a dispersive type of gel. So it's more difficult to remove compared to the other type of gel, which is your cohesive gel. So you have to be you need to take more time to really remove it. So especially making sure all clock hours. And yeah, once that's removed, then that's basically it. Okay, so here we're removing some gel. Okay, that looks really good. You can actually see the clearness of the lens already. Alright, after removing gel, then yeah, we're going to seal our incisions. So this is sutureless. So how do you achieve a sutureless closure? It's by stromal hydration. So remember that Wong incision I created, that small incision at the on top of the main incision. So we hydrate that. So when we hydrate it, it will actually tamponade this main incision, as you can see there. Also in the side ports or the side incisions, we also irrigate it or hydrate it. So that will tamponade our incisions, and this is basically leak-free. Anyway, after doing some stromal hydration, you also want to inject antibiotics to make sure that there is no risk for infection. Choices will vary. Usually I would apply levofloxacin or moxifloxacin. So you can inject it in the side port as seen here. And that should conclude the surgery. Okay, intracameral antibiotics. That's good. Okay, so you don't need to mind the bubbles, that will just go away. Alright, and do a leak check. You could use your cotton pledget or yeah. And that concludes the phacoemulsification procedure. This patient really did well and had a good outcome. Okay, so let's try to review those steps. You know, it can actually just be summarized in 3 steps, and phacoemulsification just is in itself phaco, which is the lens. Emulsification is when you emulsify it using ultrasound, and when you completely remove that, you do intraocular implantation. So those 2 steps can be broadened up into more sub-steps, and you can see here as follows. So that's incisions, local anesthesia, trypan blue staining, viscoelastic injection, your capsulorhexis, mechanical dissection, the phacoemulsification procedure itself, then finishing off with irrigation aspiration, IOL insertion, removing the viscoelastic, and yeah, basically the 3rd step, which is just to seal everything. So that's your stromal hydration, intracameral antibiotics, and your leak check. So yeah, that's pretty much it, and I hope you were able to learn something. This is actually a case during my residency. So yeah, for clerks and interns, just review the basics, while for residents, you might want to see some finer details in this surgery that you might appreciate. Thank you for your kind attention.